Thank you very much, and this is my second talk, and once again robotic, but I personally don't against anything to be done by laparoscopy. Let me just tell you what I'm going to touch on. Hepatolithiasis, we call it primary biliary stones because somewhat different from Western choledocholithiasis, which is formed in the gallbladder, but the hepatolithiasis is basically formed in the biliary tree inside of gallbladder, and very often the intrahepatic duct are being involved and characterized by repeated primary bacterial infections with stricture formation and stone formations. Very often in old days, we got patients coming in with cholangitis, open up the curve on abdomen, there would be 1 scar, 2 scar, 3 scar, so many scars because of, in old days, we don't have endoscopy. Every now and then, patients will present with cholangitis. They have to be exposed surgically, and this is the really frustrating, and you have to settle cholangitis by open surgery. And this is why I'm talking about this, because this is a disease first described in Hong Kong, day back in 1930 by Professor Digby, which is also the previous professor of University of Hong Kong. And very unique condition affecting Chinese population. The commonest term to use it, to describe it, would be recurrent pyrogenic cholangitis. And there would be long lists of different nomenclature, including Hong Kong disease, or Oriental cholangial hepatitis, Asiatic cholangial hepatitis, and so and so. But now it is still common in Southeast Asia, but a bit rare in Western countries. But bearing in mind, people are moving. People are moving from Asia to States to Europe, and you are also seeing a bit of all this disease in Western world. And there will be 2 to 10% of patients. And on long-term infection, they subsequently develop intrahepatic cholangiocarcinoma. And principal management divided in 2 parts, acute phase and also definitive treatment. Acute phase, settled cholangitis, definitive treatment, after going through all the detailed imaging study, think about the treatment strategy and eradicate the disease, hopefully it stop the cell perpetuating cycle. And acute phase, usually broad spectrum antibiotics and also build decompression. And emergency intervention is quite common in old days by surgery, now very often to be done by ERCP, if fail and go for PTBD. And very exceptionally, we have to bring patients to operating room for emergency operations. And this is a multidisciplinary approach, and I perfectly agree. I'm also a surgical endoscopy. I'm doing ERCP, I'm doing OGD, I'm doing colonoscopy, even though I'm not doing those very fascinating therapeutic endoscopy. It has also a sort of contribution and also involvement of intervention radiologists and settle it if you fail to settle it by endoscopy. And sometimes we have to think about open surgery because of technical difficulty. Of course, the gold standard is still AMAS, laparoscopic operations. Surgical option and largely free. Surgical exploration of common bile duct. When everything's settled and remove the stone, and think about the leak of biliary enteric anastomosis. Partial hepatectomy and remove the segment harboring a lot of stones, recurrent abscesses, and with a lot of stricture, and just simply remove it, and provided you got good enough remnant. The other option would be bypass, and a high bypass, plus or minus with access lobe, allow you to go in again to remove stone if stone come back, and even with facilitated drainage. Theoretically, I'm the one a bit inclined to more aggressive treatment, like partial hepatectomy, because I think this is really able to stop the cycle, because very often those strictures would be high up, and it would be very difficult to deal with it. And not to mention about by removing the affected segment, you also remove the chance of subsequent malignant transformation. But of course, you have to balance surgical risk and also preserve the function to patients. And this is a summary slide telling you what to design and the best treatment option for the patient, depending on stones, location of structure, and the number of involved liver segments, and the atrophy, and the presence of extrahepatic stones, and also how likely you're also managing somebody with cholangiocarcinoma. And for cases, and you really go for partial hepatectomy if structure high up, multiple, and atrophy with presence of recurrent abscess formations, and also suspicions of cholangiocarcinoma, and not to mention about those stones might not be retrieved by endoscopy and also by surgical explorations. Other considerations like patient condition, liver reserve, and also the frequency and severity of each attack. Can MAS be applied in the management of primary hepatodevices? It's a bit difficult in terms of how to manipulate the scope in upward position and pass it all the way up to deal with those intrahepatic structures. And not to mention, presence of structure might stop you to assess the stone harboring proximal to the structure. And not to mention about the fragmentation devices and see whether you can use it very well and without complication. Bypass is a bit demanding and suturing in narrow space, not to mention about Wu-on-Y bypass. And once again, you have to harvest the jejunal limb for the creation of X-ray anastomosis. Hepatectomy, you might have encountered a lot of distortion of anatomy. Fibrosis is the rule, and there will be a lot of adhesions, and there's also risk of parenchymal injury and end up with biliary fistulations. MAS for primary hepatodevices, conversion rate 5 to 10%. Morbidity rate is about 25 to 36%. Mortality rate is really low, just 0 to 2%. Hospital stay is a bit shorter, it's about 9 days to 14 days. Initial success, 86% to 100%, and final success rate after stone clearance is about 92 to 100%. And this is a paper reported by Seoul National University Hospital, and talking about cohort of 76 patients accumulate over a period of 20 years. And conversion very low, 8%, and mean operation time is about 280 minutes, and mean operation postoperative stay is about 2 weeks, and morbidity about 40%, mortality is about 1.3%, and stone clearance rate 87%, and final clearance rate is about 93%. Recurrent stone still happen in about 15%. This is really radical with exploration and also hepatectomy. Still encounter about 15 to 20% of recurrent stones. And this is a paper published in American Journal of Surgery, and our old paper is published in about 2010 or so. And for a patient altogether, 55 patients accumulate over a period of about 13 years. Conversion rate, 7.3%. Mean operative time, slightly more than 2 hours. And mean hospital stay is about 9 to 10 days. Morbidity, 25%. Mortality, 1.8%. And immediate stone clearance, 90%. And final stone clearance, 94%. And recurrent stone, 5%. And marine transformation happened in 2% of patients. In summary, when we go through all the non-randomized study, it seems that the operation time really is short in most of the series in favor of open surgery. But when you look at the outcome, particularly hospital stay, and I think this is quite consistently showing the merits of conventional laparoscopy. The rest of parameters are more or less the same by comparing open and laparoscopy. And this is a very old video, you can tell quite well. And this is somewhat happened more than 15 years ago. I still heavily embarked on biliary surgery, and this is cases, not just one stone, and they are altogether about 20 stones or so, and you can tell a lot of stones inside and flushing, and so many stones. At the end of the surgery, apart from exploration, we also make a longitudinal duodenotomy and join together, and final anastomosis would be womb-box shape, and that keep the anastomosis open, and you can do it in one single operation. Exploration together with CD anastomosis, and somebody would argue, would do worry about some syndrome. I think it is really crucial to make it big, at least 2 centimeters in size, and make it the most dependent part of common bile duct, and technically simple. You can learn it, you can do it, and every single cases, probably you can finish in about 2 to 3 hours. And this is the final outcome, final outlook. Robotic exploration, very few case reports and very small case series, and definitely feasible and safe after using all this expensive robotics. And this is the exploration and what we can do. And basically, very similar principle. I think the principle-wise is the same. And remove the gallbladder, identify the common bile duct, confirm it, and I can't feel it, I just pass it. Even I can't feel it, but I can tell where are the stones, because by looking at indentation, you can tell where is the stone. And this is the stone. And basically, there are a lot of stones inside. And get the bed ready, remove the catheter, and remove the stone one by one. And at the end, I also do operative cholecystoscopy to confirm there's no remaining stone before I close it. I don't close it routinely with a T-tube. I close it primarily with a single-layer continuous suture. If the common bile duct is bigger than 1 centimeter in size, and this is the way how we are doing. I think whoever is interested in doing robotic HPC surgery, and this is your start. Safe surgery, a lot of suturing skill, and risk-free, and you can really learn how you can make use of the robot and to do that simple procedure. Before you move on to talk about hepatectomy, pancreatectomy. Even you got cases like this with previous gastrectomy, I won't say I surrender. I still go for exploration with laparoscopy and robot. And of course, there's no anatomy, but anatomy is here. Anatomy is not there, but with your mindset, clear mindset about anatomy, you can figure out which is which without too much damage. And this is the exception. We put in a T-tube after exploration. Why we need to put in a T-tube after exploration? If you can do endoscopy, no T-tube. If you cannot do endoscopy, put in a T-tube. And this is a life, and make sure, and you can still able to access back to the BV tree. And even with failure of endoscopy. And this is the occasion we routinely do. How about SUM syndrome? I did mention about SUM syndrome after CD. It would be in the range of about 5% or so. And this is a patient after follow-up about 8 years. I initially performed laparoscopic CD and finally repeatedly admitted because of low-grade infection and confirmed to have a lot of duodenal reflux, a lot of food tablets in the distal and the common bile. And I take down the CD endosomosis, I harvest the whole limb and bring it up retrocolically and to do the Wu-on-Y X-ray endosomosis. And this is the final configurations. This is a video I would like to show you, a full video, but don't worry. And typical atrophic left lateral segment, and also a lot of fibrosis. You have to take down a bit of adhesion. Let me move a bit lower down the cursor. Yes. Okay, and nothing. Basically, no anatomy, and a lot of scarring because of recurrent infection. I finally decided to go for left hemisphere hepatectomy, and this is the pen, and I routinely pass a sling in the portal hepatis to prepare for Pingo's maneuver. I think this is the middle hepatic ring. And the hepatectomy is simple. What seems to be difficult, I intentionally open up the bile duct at the resection margin and put the cholecystoscope through one of the long trocar and get it full. As a surgeon, I'm able to see the picture-in-picture, and this is the picture-in-picture. And I can see the endoscopy image, I can see the robotic image, I can see where the stone, I can also use the forceps to fish out the stone. After clearance, very simple closure of the stump of the BV tree, and that's the end of the surgery. After embarking on robotic program, and this is the database, and altogether about 18 patients. And 13 of them received left lateral sectionectomy, 5 patients received robotic left hepatectomy, and there will be 11 patients with concomitant exploration of common bile duct. Mean operation time slightly more than 3 hours. Mean blood loss is about 120. And perioperative transfusion wasn't required in any one of my patients. Open conversion, 0. And number of patients with complication is about 16.7%, including some mild infections. And residual stone in 2 patients, mortality 0, hospital stay even better than laparoscopy, and it's about 7 days. And those are the long list of organisms, very often because of repeated intervention, and there would be multi-organisms inside, and wide range and drug-resistant one. So what seems to be important, apart from giving antibiotic, eradicate the infective focus, and that's the key of success. And I love this short video. People ask me what to choose, laparoscopy or robotic, and let me just give you the answer.
Empty your mind. Be formless, shapeless, like water. Now you put water into a cup, it becomes the cup. You put water into a bottle, it becomes the bottle. You put it in a teapot, it becomes the teapot. Now water can flow or it can crash. Be water, my friend.
What I can say, you might not know me, but I think most usually know about this BOOSNI, be water, be fluid. Find one approach which suits you well, be it open surgery, be it laparoscopy, be it robotic cyst laparoscopy, and what seems to be important, ensure good outcome of patients. Let me just conclude my presentation. Robotic approach for primary hepatodevices is feasible and safe in appropriately selected patients. Favorable outcome with less morbidity and short hospital stay being identified in our series. As experience goes, this procedure will be more common. Once again, come to Hong Kong. Even though we crashed the dates for the robotic for the HBP meeting in Korea, the same day, 4 to 6, but this is held in Hong Kong. Dr. Kim's meeting is held in Korea, and it's a bit difficult to choose which one you are going to join, but come to Hong Kong, okay, for that CRSA meeting to be held in October. Thank you so much. This is the end of my presentation.